So thank you so much, and we'll move on to the next talk by Dr. Mahesh P. Shanmugam. Dr. Mahesh is the head of Vitreoretina and Ocular Oncology, Shankaraya Hospital, Bangalore, and he's also the current scientific chair of VRSI. And sir would be speaking to us on dealing with tractional hypotony.
Thank you, Dr. Manisha, and it's a pleasure seeing you all this morning. So let's look at how do we manage tractional hypotony. So tractional hypotony happens because of anterior hyaloid proliferation, and we need to make a distinction between anterior hyaloid fibrous proliferation and anterior hyaloid fibrovascular proliferation. Anterior hyaloid fibrous proliferation happens post-trauma. It is not vascularized much, or if it's vascularized also, it's not too much of an issue. And post-retinal detachment surgery, particularly myopes, will have this thick tissue growing in the vitreous base region and extending onto the pars plana and exerting pull on the ciliary body. I have seen that like this post-RD surgery, in myopes it tends to happen. And if you place an encircling band and do 360-degree dense laser, somehow it cuts out the blood supply either to the retina or to the anterior choroid, and that seems to incite this fibrous tissue proliferation. And these people tend to have chronic hypotony, in myopes particularly. Anterior hyaloid fibrovascular proliferation was what happens when we do a vitrectomy for a proliferative disease like a diabetic disease or a CRVO, and then they have this sclerotomy site proliferation which grows 360 degrees along the vitreous base and which is vascularized, and they tend to be a cause for recurrent vitreous hemorrhage in these patients. So the early signs are there is usually an episcleral or conjunctival congestion at the site of the sclerotomies, and you will have this dilated choroidal vessels, dilated episcleral vessels which are dipping into the sclerotomy, and that's a sign that like these patients are developing a sclerotomy site proliferation. And as I mentioned, proliferative disease, they may have recurrent vitreous hemorrhage, and they may develop an unexplained rubeosis iridis, and in the initial stages they may have increased intraocular pressure and subsequently go on to develop hypotony. And in a phakic patient, they may develop unexplained posterior synechia, and slowly they start developing iris retraction, and then hypotony happens along with iris retraction. So the issues are, do we intervene, and when do we intervene? And persistent hypotony, of course, results in phthisis. In a gas-filled eye, when these start developing this anterior hyaloid fibrovascular proliferation or fibrous proliferation, they tend to progress very, very rapidly, and the retinal detachment becomes very complex, closed funnel very soon. In an oil-filled eye, because of the oil, it masks the changes. So you're not able to make out that this anterior hyaloid proliferation is happening. So a late intervention, it can become irreversible, because the longer the ciliary body has been pulled because of the fibrous tissue, the atrophic changes happen in the ciliary body and they don't recover. And if there is a visible retrolental membrane, a vascularized or non-vascularized membrane, which is bridging from one side of the ciliary body to the other side behind the lens, and along with that, there is a long-standing hypotony, these eyes don't do well, and it might as well probably leave it, or try to make an opening in the membrane so that the patient continues to see with the oil inside the eye. But like doing surgery in these eyes is very difficult because the ciliary body and the fibrous tissue is pulled forward, and placing the sclerotomy and going inside causes the retinal detachment again. So let's see some of the examples. So this is a patient with phakic anterior hyaloid fibrous tissue proliferation post-trauma. Post-trauma eyes are reasonably okay to manage because the site of the globe rupture or the perforation is where the fibrous tissue proliferates, and that's the only thing which would have to be dissected. So we dissect it and then segment it away from the rest of the vitreous base and isolate that tissue, then it doesn't tend to proliferate and remains in that area. So in a younger patient such as this, where the lens is not too thick and it's clear, with the proper depression, we should be able to reach up to the anterior part of the vitreous space and the ciliary body and dissect the anterior hyaloid. So this is another patient with a post-traumatic localized proliferation. So here we are dissecting this fibrous tissue which is grown at the site of the perforation or the trauma, has grown at the vitreous base, then extending on to the pora serrata, then the vitreous, then the ciliary body, and it can extend almost up to the iris as well. So there's a localized area of fibrous tissue which is being dissected. These patients may not present with hypotony, but leaving it alone, what happens? This fibrous tissue grows 360 degrees and causes traction on the ciliary body. So these are simpler ones where we will be able to salvage the size and the intraocular pressure can come back. So and usually the retina is pulled up as well, so we may have to do a relaxing retinectomy there and reattach the retina. There is a much more complex fibrous tissue proliferation. The wound is at the site of the limbus. So you can see this thick fibrous tissue growing posteriorly and exerting traction. And we will see that there is a traction retinal detachment. You can see that there is a traction recommended retinal detachment with radial folds. You can see that radial fold extending to the site of the proliferation. So here, all the pre-retinal membranes would have to be removed, then cut the retina and relax the retina, and then try to limit the site of the area of the scar and delimiting it from the rest of the vitreous base so that it doesn't progress 360 degrees. So here, as I was dissecting, I found that there was a foreign body which was sitting there within this scar tissue, which was removed. And we isolate this scar tissue from the retina, anteriorly the ciliary body and the iris if it is possible, but from the rest of the vitreous base. So these eyes with the localized fibrous tissue, the anterior proliferation, tend to do well, and they don't go in for a hypotony as well. So that's the reattachment to the retina with oil. So here we will find that this fibrous tissue grows from the vitreous base across the ciliary body and onto the iris. And we will see that the ciliary processes are all gathered together. So we'd have to use a combination of the forceps as well as the cutter to separate this fibrous tissue from the ciliary process and relax the ciliary processes so that they are able to function. So that's what we are doing. So this has to be a careful maneuver because we may be cutting into the ciliary process as well. And this fibrous tissue again grows anteriorly to the iris and starts retracting the iris. So we dissect between the iris and the ciliary processes and remove this membrane. You can see that the inferior PI is blocked because of this fibrous tissue. So release this fibrous tissue from the adhesion to the iris as well as from the ciliary body and dissect it. This sometimes can be very nastily difficult because it can bleed because we're cutting into the ciliary process, or we may be cutting into the iris as well. But with careful dissection, we'll be able to relieve this circumferential traction and get the ciliary body to function again. So here we find that the anterior hyaloid is very thick, and particularly if you have left behind a capsular rim, that also becomes part of this anterior hyaloid fibrovascular proliferation. This is so thick that the cutter cannot cut. So it's dissecting it bimanually from the ciliary body and releasing it. And we have to do a limbal incision to remove this fibrous tissue. Fortunately, this patient, as you can see, the iris is not retracted. So possible that patient may recover if the ciliary body has not gone into atrophy already. Then again, most of these eyes will need a 360-degree retinectomy, which is reattached. But the fibrovascular proliferation associated with proliferative disease is different. So here we have a patient with a combined retinal detachment who was operated, the retina was reattached, but then started developing this reproliferation of tissue. Here, the posterior reproliferation is being dissected out. And these are the eyes which will progress very rapidly. And if a patient comes with a recurrent vitreous hemorrhage about 6 months down the line, post-vitrectomy, we should suspect that there may have anterior fibrovascular proliferation and intervene rather than wait and watch, because these eyes can progress very, very rapidly into very severe anterior proliferation. So everything is going on well as far as the posterior part of the tissue is concerned. We are able to remove all this posterior part of the tissue. But we come anteriorly, you can see this thick, broad band. So this band of tissue is the one, the whole vitreous base is converted into a thick, broad band of tissue. And this can't be removed because it is so stuck to the ciliary, the underlying choroid. If we try dissecting it, it bleeds so badly. So these eyes would have to be left like this and hope that they don't go in for iris retraction and oil into the anterior chamber. The difficulties in dissection are, as I mentioned, when we dissect so anteriorly, we are depressing on one side. A little slip in the depression can have a cutter cutting into the ciliary process, and a massive bleeding can happen like this. So you can see the massive bleeding. We may cut into the ciliary body or the ciliary process, and you can see the blood is stuck under the retina where we have done the retinectomy. So this is our issue. If in case there is severe anterior proliferation, you can have iris retraction and silicon oil keratopathy. So if it's a localized proliferation, as I mentioned, if it is traumatic, we can think of doing a pupilloplasty and narrow down the pupil so that the oil doesn't come into the anterior chamber. This can be done easily. As you can see, inferiorly is where the iris is retracted. So we can try to make the pupil round by doing pupil small by doing a pupilloplasty. This is a standard 4-throw pupilloplasty and can in fact create an inferior PA as well as a small pupil. This may not be possible in all the situations, but in limited anterior proliferation, we can do this. But in case there is, you can see the completely iris is retracted, you can do the oil retaining sutures. It's like pretty much a modification of how you do a scleral fixated intraocular lens. I put a square and Divyans put a star. It depends on how you want it. So this is the same standard 10-0 proline which we use for the SFIOL. So you can create this square so that the oil tends to remain posterior, and we usually put a 5000 centistoke oil because oil cannot be removed in these patients. So to summarize, anterior proliferation is serious, often irreversible, post-trauma, probably salvageable because it may be a localized area of anterior proliferation resulting in hypotony. Post-retinal detachment, possibly salvageable. Post-PDR, most often lost because of the very thick fibrous which forms anteriorly. Anatomical success is possible if there is anatomical success in the sense we may be able to attach the retina, but then we may not be able to salvage vision in this size because of the hypotony and the oil coming into the antechamber and silicon oil keratopathy. Iris retraction results in keratopathy. So there are some of the broad guidelines. If iris is not retracted and the IOP is around 6 to 8 millimeters of mercury, it may recover, and these are the patients where we treat them with subtenon steroid and topical steroid. Localized iris retraction IOP is normal or high and younger prolif. Younger prolif in the sense early in the disease, so that it's not caused ciliary body atrophy and just about pulling on the ciliary processes, we may be able to recover the ciliary body if we relieve this traction. So this is where we do a surgical dissection and pupilloplasty. And if the deep anterior chamber, because the iris is being retracted posteriorly and early iris retraction, and the pupil is blocked on oil in the anterior chamber, we can attempt surgical dissection with steroid, and then we hope and pray that things will work. Iris retracted, oil in the anterior chamber, all we can do is to try keeping the oil from the endothelium by doing oil retaining sutures. Thank you very much.
Thank you so much, sir. And I think majority of the cases that you showed were all desperate cases. I just had a quick question. Any question from the audience? Just a quick question, that when would you not attempt dissecting out those membranes where you feel that after this much of time has passed, probably now the ciliary body is not going to take up its function because of the traction?
As I mentioned, if there's a complete membrane behind the lens extending from one side to another and long-standing, in the sense like more than 6 months, then I would probably not. I'll try to create an opening in the posterior part of the thing and leaving it behind. And that other patient where I showed a proliferative disease. So I go inside and find this thick band of the whole vitreous base has converted into a fibrous tissue, all 360 degrees. That again, I will probably not attempt dissecting, because attempting dissection in this is very difficult because you'll be cutting into the choroid, it'll bleed, and you'll be